But yeah, we'll just touch on renal angiomyolipomas and current evidence and advances in management. This is just the outline. Mostly going to really touch on the diagnosis a little bit, the natural history, and then where treatment has gone in the last 10 to 20 years from a transition from surgical intervention to more active surveillance and some new advances in medical management. So as Dr. Glebe mentioned, AML is a benign solid renal lesion, and it's a neoplasm occurring in the kidney, which is composed of 3 tissue types: blood vessels, smooth muscle, and then the hallmark of diagnosis is the adipose tissue. And there's 2 main clinical subtypes. So we have sporadic AMLs, which occur in 80% of the time, and then hereditary AMLs, which occur 20% of the time, and those are broken down into tuberous sclerosis complex, as well as lymphangioliomyomatosis, or you can have a combination of both. So there's been multiple retrospective studies, mostly looking at the epidemiology of sporadic AMLs. Incidence is quite low, 0.3 to 3% in the general population. Again, this is on the rise just due to the increased number of people getting scans, whether that be ultrasound or CT scan. And the female to male ratio is 3 to 1 in sporadic. However, this is one of the larger studies looking at over 60,000 patients of sporadic AMLs, looking at the incidence. And the average age of diagnosis was in the 40 to the 60s. Size was relatively small, 1 to 4 centimeters, and overall quite a slow growth rate. And we'll touch on the TSC associated AMLs, which behave quite differently. So this is an autosomal dominant condition. 1/3 have a family history, and then 2/3 is just sporadic mutation. The incidence is 1 in 10,000, although this is presumed to be underdiagnosed, as many people may have AMLs that actually doesn't come out that the diagnosis is TSC for much longer. Of people with TSC, 50 to 80% of them will develop AMLs. It involves a genetic mutation in the TSC1 and TSC2 genes, and they basically interact in a protein signaling complex to negatively regulate cell growth. So there's often an association with more systemic disease with TSC as well, mostly including facial angiomyofibromas, epilepsy, and intellectual disability. The mutation is mostly in the TSC2 gene, 70 to 80%, and this often causes more of the systemic manifestations. So when there's deficient or defective TSC1 or TSC2 gene, it activates the mTOR pathway, which can cause cell growth, proliferation, and angiogenesis, which is why I'll touch on a bit later how much of the medical management has been looked at targeting suppression of this growth with mTOR inhibitors. And then with regards to the hereditary conditions, I'll touch basically on just the TSC complex because the LAM is much more rare. But this is often manifested by multi-systemic disease, larger size, higher growth rate, bilateral AMLs, and average age of diagnosis in the 20 to 30s. This is a really busy slide that I won't really get into significantly, but the main point I wanted to make here was that with TSC complex, it can be diagnosed either genetically or clinically. And for clinical diagnosis, there needs to be 2 major features, or 1 major and 2 minor features. And 3 of the major features that are the most common are these facial angiofibromas, the angiomyolipomas more than 2, or subepidermal giant cell astrocytoma, which is the reason why I'll touch on a bit later, is you need to get brain imaging as well. But I think the most important point here is that genetic testing is crucial, and you can confirm the diagnosis, which can guide genetic counseling. And I think for these patients that get diagnosed early or get missed, I think the role of genetic counseling, confirmation of diagnosis, can really accelerate surveillance or therapeutic intervention. And there is a difference of how you would want to treat these or manage these between sporadic and TSC associated. With regards to clinical presentation, the classic triad is flank pain, hematuria, palpable abdominal mass. However, this rarely actually occurs, and most of them, 80%, are found incidentally and are asymptomatic, found on a scan for some other reason. The most catastrophic complication is this retroperitoneal hemorrhage called Wunderlich syndrome. And you can also develop hypertension, anemia, and kidney function impairment. I just highlighted this study on the right here. And the reason for this is a study from the 80s, but it really has been the basis of all management of AMLs. They reviewed 253 patients, showed that 65% were symptomatic, 82% symptomatic with a tumor size of greater than 4 centimeters. And based on this study, our historic management has been treatment of AMLs of 4 centimeters or higher. However, a number of more recent reviews have shown that potentially only 10% are symptomatic, with 2% being a risk of hemorrhage. So important to highlight this because a lot of studies moving forward really use that 4 centimeter cutoff, as we'll see, but there needs to be some changes. So when we talk about the diagnosis, a lot of the time, ultrasound is the first scan. Just because someone presents incidentally to emergency department, it's accessible, it's cheap, so we get an ultrasound, and it shows this mass in the kidney, mostly showing hyperreflective, hyperechoic lesion. However, it's important to note that with regards to RCC, there's an overlap in ultrasound of around 12%, and the smaller the RCC gets, the chance of overlap increases. So for that reason, it is not the hallmark of diagnosis. This was an interesting study, actually just from 2023, and it was trying to distinguish if there was any findings on small masses less than 3 centimeters to distinguish between renal cell carcinoma and AMLs. The significant findings here basically showed that AML had a higher, on ultrasound, looked more lobulated, looked more irregular shape versus the RCCs, which were more round and more smooth. Again, subjective, but the hallmark of diagnosis is a CT scan or MRI. So main findings on CT scan are this homogeneous enhancement, delayed washout, high intrinsic attenuation, with Hounsfield units less than 10. And this confirms that it's actually fat. With regards to MRI, obviously it's less accessible, but it is better at distinguishing whether or not this is truly an AML. And it's hyper-intense in the T1 weighted sequence and hypo-intense in the T2 weighted sequence. And I have a couple of images that I'll show. Up until recently, there's been no radiological classification system for renal AMLs. This study in the bottom here, Song et al., basically did a review of 98 histologically proven AMLs. So they took the samples and basically broke them down into fat rich, fat poor, and fat invisible. Because this is a big distinction. 95% of AMLs will be fat rich. However, there are a small number that will be fat poor, and an even smaller number that are fat invisible. And that, when it becomes indeterminate like this, it's difficult to determine whether this is AML or potentially a more malignant cause. So just on imaging, just briefly. So this fat rich on the left here is a fat rich AML with the negative 74 Hounsfield units. And then on the right, this is actually an RCC containing a small focal fat area, but it's much smaller than the size of the lesion. And interestingly, a few studies have noted that if there's any curvilinear calcification or signs of necrosis, even if the lesion is more fat appearing, that's more concerning for potentially RCC. And then on MRI, this shows this hyperintense mass on T1 weighted. And then they also talk about on MRI this India ink artifact, and it's where this arrow is pointing. So it's this dark line basically around the mass, and it's at the interface between the mass and the kidney. So what about these indeterminate lesions? Again, less than 5%, quite a small number that may be AMLs, but there's no fat content. And these are the epithelioid AMLs, and the only ones that Dr. Black or Dr. Gleave care about, because they are the only ones with any malignant potential. And with regards to the guidelines, they say that this has to be basically worked up from an indeterminate solid region mass standpoint. And this study on the right here looked at 57 studies, over 5,000 patients, looking at the accuracy and complications of doing percutaneous renal tumor biopsies. So they compared core biopsies with fine needle aspiration, and basically core biopsy, higher sensitivity, higher specificity, very low number of complications. However, the 2020 CUA guidelines or update basically said that any suspected renal AML should be confirmed with CT scan or MRI, and biopsy may be considered if neither CT or MRI are diagnostic. It'd be interesting to hear people's opinion, because when I was trying to look in the research, one, there's no studies suggesting any specific imaging findings to suggest biopsy, and two, my understanding is the current practice guidelines, people will often not even do a biopsy and they'll just go straight to intervention with partial nephrectomy. But the point we can talk about after. Well, that's a good segue into the natural history. So this is a big part of the talk. It's been, based on this findings from Osterling showing that 4 centimeters, we need intervention. I think over the last 20 years, there's been a big shift into what we actually do need to treat and what we can monitor or just watch with surveillance. And traditionally, we treated over 4 centimeters. I think a few of the questions that I want to answer over the next few slides is basically how many patients had intervention or adverse outcomes when we use surveillance above 4 centimeters? Do we want to intervene proactively based on imaging, or do we wait reactively based on symptoms? Is there a certain size that we should start to offer surveillance? Are there certain situations where we need to follow these lesions regardless of size? And does this change with symptomatic presentation? So this is one of the larger studies. It's retrospective. They're basically all retrospective, single center, confirming AML with a fat lesion on CT. So importantly to note, for the next few studies, basically all AMLs were diagnosed with fat lesion on CT. So you're missing out on all these fat poor or fat invisible AMLs for the majority of these studies. This is a large number, 2,700 patients, but only 440 were actually followed for a median of 43 months. This is from EU, it was like the States as well, Toronto and multi. It's from I don't think it was Toronto. The finale, but anyways, I can't remember the exact site it was. But interesting to note is that a significant number had less than 3 images and weren't followed. And the overall intervention rate of this group who weren't followed was 0.56. Of the rate of the 440 patients who were followed for 43 months, the intervention rate was 5.6. So less investigation basically leads to less intervention. And there were still very minimal presentations with retroperitoneal hemorrhage or catastrophic complications. With regards to significant predictors of intervention, this study showed TSC status, clinical presentation, whether they were symptomatic, and again, using this initial size cutoff of 4 centimeters, which is used basically throughout. Their main goal here was to look at the growth rate of untreated AMLs. And interestingly, regardless of the size, less than 4 or greater than 4 centimeters, there was no significant difference in the growth rate in the length of follow-up, which again was a pretty extensive number of years. So 91% of lesions had no growth, or extremely minimal at the median follow-up of 43 months, and 9% grew with a rate of more than 25 centimeters a year, mostly associated with the TSC complex. This was another decently large study, retrospective from the Cleveland Clinic. Again, AML is confirmed with fat lesion on CT. Looked at 400 patients, and the main goal was looking at the active surveillance group and what factors predicted them to go from active surveillance to active treatment. Interestingly, they did not talk about in the paper initially why these patients were either assigned to the active treatment group or the active surveillance group. So there's already a bias there of, 130 were active surveillance, but why were these 270 put to the active treatment group initially? They don't really mention that. Follow-up was 49 months, and over that time, only 13% discontinued active surveillance and had to go to active treatment. Main reasons being 35% flank pain, 23% mass growth, 17% hemorrhage, patient preference, and then 6% gross hematuria. Again, significant predictors to switch from the active surveillance to active treatment group were growth of the tumor, as well as symptomatic presentation. However, it is interesting to note that of the 38 people with a lesion greater than 4 centimeters, only 34% of those people actually discontinued active surveillance and had to be treated. So if we're looking at that number, if we decide to treat everyone at 4 centimeters, then we're over-treating potentially 65% of these patients. And 67% of symptomatic patients were just managed with active surveillance with no ever delayed intervention throughout the follow-up period. These Kaplan-Meier curves just show that besides the diagnosis, a significant proportion had intervention by 24 months. And then with regards to symptoms, just a steady increase in intervention rates over the follow-up period. Well, presumably these 38 patients came in and were extremely symptomatic, or the provider thought, this growth rate is maybe too high. Yeah, true. So more than 65. Oh, maybe. The bleed rate? Yeah. So, from initial studies, it was 20%, 30%, but now there's yeah. But more recent studies have shown, less than 5%, less than 3%. Seems the longer that these studies are going on and the further they're looking at these groups, the actual risk of hemorrhage is significantly lower, especially with the sporadic. There'll be some numbers in a little bit. This was quite a small study, just 34, and there was no really significant relevance, but I thought it was an interesting concept. And I think moving forward, a bigger study trying to look at what factors actually contribute to spontaneous rupture. This one really trying to look at tumor size, again, which has been used a lot, but 4 centimeters just doesn't provide any serious information. This one also looked at aneurysm formation, but there was no significant difference. Again, only 6 patients in this study had rupture, so there needs to be a study with a significant larger number. This was an interesting study, trying to create a scoring system to predict rupture and hemorrhage. Because again, we're trying to just figure out when do we need to treat and when can we monitor these and what are these predictive factors. So this looked at 460 patients with sporadic AML. 300 of them basically were used to create this training set. And after multivariate analysis, there were 4 that were significantly correlated with rupture. These were, again, symptomatic at presentation, tumor size, whether or not it was more or less than 50% exophytic growth, and then whether the tumor blood supply was poor or rich. Again, a super vague term, and the study didn't actually highlight what that meant. Like, how did they distinguish poor blood supply versus rich supply on imaging? But interestingly, they used these to create a scoring system between 0 and 3. And then they applied this scoring system to 130 patients for validation. And there was a significant difference looking at the low risk group of a score from 0 to 6 versus the high risk group, 7 to 9. So it's really been the only one that has created a scoring system. It's not used, but again, interesting concept, and interesting to maybe in the future try to create another type of scoring system just to help with. This was like, yeah, this was all done in China. This study was a Chinese study. I didn't get a huge sense. It was mostly male, female. I didn't, racial wise or ethnicity wise, I didn't find anything significant. I know, seems weird. I don't actually know. Presumably, I mean, you need to have imaging like MRI, CT. Yeah. I don't know I don't actually have that number. So with the Canadian Urology Association best practice report again from 2020, looked at 9 articles, retrospective, 1,100 patients. Overall, 92% of people are asymptomatic. 9% overall show growth. The average growth rate quite low, 0.4 millimeters a year, and the overall risk of hemorrhage, 3%. Again, when it's broken down between less than 4 and 4 centimeters, risk of hemorrhage goes from 1% to upwards of 16%. However, I think there really does need to be a further clarification of different centimeter groups. So, most of these studies are 4, less than 4, greater than 4. But I'll show some that break it down to a few more different groups. This was a large study looking at 30 years of data, trying to distinguish factors predicting active treatment. Again, AML on CT scan, just the fat-containing ones, and what factors were predictive of active treatment versus active surveillance. With regards to active treatment, 88% went surgical excision and 13% went angioembolization. I'll show some studies further. That number, this seems quite high number of surgical versus angioembolization. A lot of the time, people will often go angioembolization first. But in this study, 77% female, 70% asymptomatic at presentation. Interestingly, this study spanned quite a long time, 1990 to 2020. And one of the factors predictive of active treatment was actually the year of diagnosis. So before 2010, there was a much higher number of providers providing active treatment versus surveillance. So 50% probability of active surveillance before 2010. And then after 2010, when some of these studies came out saying, I think you can monitor these 4 centimeter ones just with surveillance, then the probability of active surveillance actually went up quite a bit, to 75%. Again, it's inversely proportional to tumor size. So yeah, the tumor gets bigger, the probability of active surveillance decreases, but that exact sweet spot of which centimeter you need to treat potentially, there isn't a clear cutoff for that. Yeah. Yeah. Exactly. So I mean, ultimately, the bleed is the catastrophic one. If symptoms cause someone to come to emerge, 10 times, then I guess that's a different discussion of whether or not that needs treatment. Quality of life and this was a follow-up study on that initial one I showed. So this was one of the only ones that actually looked prospectively. So it took that data, then followed these patients for another 5 years. And their main goal was what was the growth rate of these untreated AMLs and what was the rate of intervention. So again, 90% less than 4 centimeters, as Dr. Patterson mentioned. People come to emerge, they find these small lesions, and what do you do with them? And of this group over the 5 years, only 7% received intervention. And only 0.7 of these actually presented acutely, so only 3 of these 460 patients presented acutely with either hemorrhage or significant retroperitoneal flank pain. Yeah, these ones were large, 18 and 29 centimeters. So median number of scans per lesion prior to any type of treatment was 4, and the median frequency of scan was about 0.8 a year. They also looked at this probability of treatment after 24 months, and lesions less than 6 centimeters by 24 months, about 15% probability of needing treatment, whereas when you get over 6 centimeters, number goes up to about 60%. And they calculated the number needed to treat prophylactically to prevent 1 emergent bleed was 198, and in AMLs less than 4 centimeters to prevent 1 elective intervention was 82. So quite large. Yeah. I know, we gotta get going. So in their conclusion, surveillance they suggested was not needed more than once per year. And in low risk lesions, less than 4 centimeters, confirmed slow growth, you could even go every 2 years. And then with these higher risk lesions, they suggested more frequent observation. They said you could basically push back to the community for observation with re-referral if there was any concerns. And then in this study, they suggested switching to ultrasound for ongoing surveillance, just to help with ease of accessibility and safety. So big question now that most of the management has transitioned to active surveillance, what is the recommended follow-up? So there's really no guideline that standardizes this. The CUA guidelines suggest that for these active surveillance patients, you need to do physical exam, renal function, CT at 6, 12 months, then annually. EUA suggests that if these are stable of a growth rate less than 0.25 over the first year, then you can actually monitor with imaging every 2 years, and you could even just do it with ultrasound. And none of these studies or guidelines really suggest a definitive timeline on cessation of monitoring. Is this for 5 years, 3 years? They don't really address this. With regards to the TSC guidelines, they suggest needing an MRI of the abdomen and brain every 1 to 3 years. Main reason for this is the TSC have a much lower fat content, so it's this, which you can't really see on CT or ultrasound. And then many of them, they have these brain tumors, which need to also be monitored regularly. The more so the LAM, TSC is, and then the LAM combination is also more associated, as well as the epithelioid variant. So with a push towards active surveillance, there's also been a push towards, well, we don't need to operate on these people, so can we just manage them medically? Yeah. There's no it's not just based on a number, basically. Yeah. You need to take the patient and symptoms, whether their growth rate, whether they have another condition. There's not, if they're 6 centimeters, it doesn't mean you have to potentially treat that. Sorry. Interval aneurysm size? Oh, yes. Sorry. Yeah. Yeah, I have a slide at the end. It's about, five, I think it's 5 millimeter, more than 5 millimeter is the recommendation for potential treatment. So with regards to medical management, study by Dr. Kapoor actually, looking at the evolving strategies in the treatment of TSC complex angiomyolipomas. This study looked at localized treatment with surgery, but also systemic interventions. I just wanted to, from this study, I just looked at the 20 studies looking at pharmacological interventions in the treatment of TSC. And there were a few phase 3 trials. So the biggest one is this EXIST-2 phase 3 trial. And it basically, as we talked about previously, mTOR pathway gets upregulated. So the thought was, can we use an mTOR inhibitor to help basically slow the progression of growth of these AMLs? This was a randomized trial. And they looked at evaluating giving 10 milligrams daily of an mTOR inhibitor in AMLs that were greater than 3 centimeters. And there was a significant response. 42% responded with either a reduction in AML volume greater than 50% relative to baseline and absence of any AML progression. And in this study, there was actually a higher rate of discontinuation for the placebo group than the group taking the mTOR inhibitor, indicating that, you know, the side effects, although not benign, are actually tolerable and worth giving this a shot. So they extended this trial to follow it up over 8 months, then 29 months, then 39 months. And the response rate basically improved throughout these median follow-up times. So up towards 56% response rate by 39 months of duration. Importantly, the side effects, this is just a chart that shows basically the side effects in greater than 20% of the patients, and they aren't benign. The main ones being stomatitis, nasopharyngitis, and then one on here that's not on here. That's a big one is also anemia, which is important to follow up. And everolimus, they looked at sirolimus as well. I can't pronounce these words, but the only one with high level evidence is everolimus in TSCs greater than 3 centimeters. A few limitations with this study. Again, the optimal duration remains unclear. Do you have to continue this for 1 year, 2 years, and then stop it? Will the tumor start to go back, or does it actually suppress this and not go back? None of that information is available or has been studied. And they didn't look at anything related to complications with regards to actually renal hemorrhage, long-term kidney function, or need for any additional interventions such as embolization or surgery. So if it works in TSC complex, why can't we just give this to patients with sporadic AMLs, which account for 80% of them? So this was a phase 2 trial. The goal was to recruit 43 patients and give them an mTOR inhibitor, but the trial was at an early termination of 20 patients if there was significant adverse events. And the main reason for this was, you know, this is a benign lesion that is often asymptomatic. So the threshold to terminate this trial based on symptoms was quite low. And as you can see here, as we have on this slide, basically the goal was to give patients 10 milligrams daily for 4 28-day cycles. If there was a volume reduction in tumor size, then they would continue for another 2 cycles, so up to 6 cycles in total. If there was no volume reduction after the 4 20-day cycles, then they would just stop and then have follow-up imaging. So there was only 50% actually completed 4 cycles, and then only 35% completed 6 cycles, and 40% withdrew to side effects, and 20% withdrew to the protocol-defined measures. So basically 20% didn't see a response of more than 25% tumor growth, and so then they were stopped. And there was a significant decrease in tumor size, as well as suppression of growth, but there was too high rates of side effects, and the reason this study was basically stopped. So it does work in sporadic AMLs, but it for a benign tumor where someone is asymptomatic, the side effects that they experience ultimately was a reason for not recommending this as a treatment for sporadic AMLs. Yeah. Yeah, so there, I didn't add them all because there was a bunch more studies, but yes, it does show that it is active, so it does work. But the side effects, someone's willing to go through some of those side effects if it's going to potentially lead to a treatment. But
do you mean it's active not because they respond, but because there's evidence of altered signaling proteins within that pathway? Is that what you're asking? So that's the question. Is there evidence that there's alterations in the mTOR pathway?
Yeah, there is
in sporadic.
Yeah, I just didn't include them, but I can send some along after. Yes. So I was trying to call BC Cancer and actually look up, practically speaking, how do we actually go about getting this prescribed and covered? But
so it's only covered if you have third-party insurance. It doesn't have to go through BC Cancer.
No,
go through us.
Okay.
And if a patient doesn't have third-party insurance, you can get sirolimus on special authority. But they also want annual sort of progress reports on the imaging findings and clinical outcomes to justify another year. It's quite painful because these patients typically have many lesions per kidney, and they actually want you to sit down and measure them and tell them what the outcomes are. But with the sirolimus, you have to monitor serum levels. So there's a target serum level, and you also have to monitor cholesterol and a few other things. It's easy to do. And if you have these AML or these what do you call them? Tuberous sclerosis patients where their kidneys are just packed with AMLs, they're generally quite happy to assume a little bit of toxicity.
Right. Yeah, exactly. Versus the sporadic where it's like someone's saying, well, I don't want any side effects if I don't even notice I have this one lesion that's hardly growing. Is that how you do it? Yeah. Right. There actually, it was this study or another one. If the patient was side effect, they did dose reduce to 5 milligrams and see, but I didn't include that one in here. But yeah, I don't know why they picked 10, but they did look at 5. So I know we're running out of time here, but I'm just going to quickly touch on, the embolization side of things and the symptoms and the complications. And that seems to be the first line treatment is embolization. And I just wanted to touch on some of the main points. So this looked at 10 years retrospective. 49 patients underwent prophylactic or emergent embolization. And the goal was to look at the safety and efficacy of embolization. Again, the biggest thing with embolization is there's a very high re-embolization rate. So this study showed a re-embolization rate of 20% of patients. So, talking to patients, whether you're distinguishing between giving them surgery or embolization, you have to really tell them that, embolization may not even reduce the tumor size. It may not work. And the chance of re-embolization is quite high. again, there was in this study, no significant difference with regards to renal function pre and post embolization. And the complication rate was about 55%, and this was mostly associated with post-embolization syndrome, which is basically flank pain, fever, vomiting, nausea, increased white count during the first 3 days after procedure. It's relatively benign and just managed conservatively with analgesia IV fluids. So although it's quite prevalent, it's quite easy to treat, and it's not a significant complication. So this was another study looking at embolization for large angiomyolipomas, and again, 10-year follow-up. Main goal, assessing outcomes after embolization. So 20% in this study had a major clinical event, and the re-embolization rate in this study was 41%, which is more in keeping with these reviews, which I'll just highlight in the next slide. And the average time from initial angiomyolization to repeat was 2.1 years. There's a size reduction in 27% of these at 10-year follow-up. So it's safe. It's a safe option for patients with symptomatic AML, but there is a significant chance of having to have a second procedure or more. So I think it just I think if the growth just like it works for a time and then blood flow. Yeah. Yeah. Right. And I think that's why, it's important just to go over, like, talk to the patient and have, because basically Canadian guidelines show that first line is surgery or embolization. They're both considered first line, and there's no real trials comparing surgery versus embolization. And so it really comes down to provider and patient discussion. Yeah. Which is why I think majority of people will go with embolization before. And then with regards to acutely bleeding, acutely hemorrhaging patient, first line is embolization. This study, I don't really need to significantly, but it basically it highlights that of the patients, you can see it in bottom right graph, the rate of basically re-intervention. For the other ones is pretty much nothing. And then with regards to embolization, it increases over time. Yeah, so there's just a few nice flowcharts that I found that I think helped, because it's still a bit confusing about what we need to do. And basically the big one being, if it is indeterminate on CT scan, then do we proceed with biopsy or do we proceed with intervention based on the provider? And then with regards to symptomatic versus asymptomatic, high risk include large size, growth greater than 2.5 millimeters a year, intralesional aneurysm size greater than 5 millimeters. And then they also talk about these risk factors such as poor patient compliance, high risk occupation for females on hormonal therapy. I didn't get into the estrogen side of things, but that's another area that's been shown to increase the rate of growth of AMLs, which is why the female to male ratio is about 3-1. There's been no real studies on these poor patient compliance versus high risk occupation. So something that needs to be followed if you're someone who doesn't have access to healthcare, or, living in a remote setting, or potentially working a job that is high risk. May need to be followed more closely, or decide to intervene at an earlier date. They talk about pilots, I guess. Astronauts have to get their appendix out before going up there. That still is considered. More close follow-up. Yeah. So there's actually there's no studies that show like after embolization, does that change the surveillance? Do they need surveillance more frequently? Yeah. Do they need a procedure? Presumably, based on the studies, is that these people would get embolization and then they would just be followed clinically for time. Not usually. Ideally, but that doesn't happen. No. Of hemorrhage, yeah. So need to have some future studies. Again, this is also just another nice flow chart. But basically, in conclusion, vast majority of AML is asymptomatic, extremely low risk of hemorrhage, and can be just monitored with active surveillance. And there is increased risk of symptoms and hemorrhage in lesions larger than 4 centimeters. But again, no high level evidence. And most of these studies just use this 4 centimeter cutoff based on that initial previous study from the 80s. And the need for treatment currently is based on symptoms, size greater than 6 centimeters, growth greater than 2.5 millimeters a year, aneurysms greater than 5 millimeters, or again, as we mentioned, high risk profession, or lack of access to healthcare living in a remote setting. And then given the progressive nature of TSC, there really needs to be a multidisciplinary approach with regards to managing these patients, urologists, nephrology, genetic counseling, etc. Yeah, that's it. Thanks, Dr. Ng, who helped, but is on a cruise ship right now, so out of service. And then Dr. Kavanagh also provided a lot of help with going over some of the slides and the studies. So thank you, everybody.